Hi, I'm Dr. Marvin Natowicz. I'm a medical geneticist at the Cleveland Clinic and professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. We're fortunate today to be speaking with Dr. Harland, a gastroenterologist at the Massachusetts General Hospital in Boston and staff at the Harvard Medical School. Dr. Winner is a nationally recognized authority on gastrointestinal issues in persons with autism, and that is the topic that he'll be speaking with us today about. Thank you so much for being here today, Dr. Winter.
What we hope to accomplish in the next few minutes is to discuss the clinical aspects and lessons that I've learned from my patients about specific gastrointestinal conditions and how they present in individuals with autism. And then finally, we'll talk about the relationship between the microbiome and behavior. So gastrointestinal dysfunction is common in individuals with autism. Common conditions such as constipation, diarrhea, gastroesophageal reflux, bloating, and intolerance of specific foods are often reported by patients and families. There really is no unique GI pathophysiology that's specific to individuals with autism. However, over the years, emphasis has been on food, and many parents have observed that modifying a diet by restricting certain foods may be beneficial for their children. So what can we learn from our patients? So there are not GI disorders that are caused by autism, but there are comorbid conditions that are associated with autism. We often do not recognize the signs and the symptoms of gastrointestinal disorders in individuals with autism. And so one of the questions is, how can we learn to understand what individuals who are on the autism spectrum are trying to tell us? So what is this patient saying? This is in different languages. If you don't speak those languages, you'll have no idea what the individual is saying. What are these patients saying? One patient is lying down on the floor, pushing on his stomach. The other patient is biting her hand with some self-injurious behavior, and the other patient has hit her head and caused a bruise on the side of her face. What are they saying? They're all saying, I have abdominal pain or a stomach ache. And part of the issue is that we as healthcare providers often don't recognize what the patient is saying, because in medical school we learned that there are certain signs and symptoms of abdominal pain that may not apply to individuals who are not speaking that same language. So I'm going to illustrate this by a few cases of patients who I have seen over my career. The first is a 6-year-old boy with nonverbal autism who's referred for a GI evaluation because of recurrent vomiting, self-injurious behavior to himself and to others. When he came into the office, he had a helmet to prevent him from harming himself and from biting other individuals. He was in restraints, including on his legs, as he would often try to run away. He held a bucket as he vomited as many as 100 times a day. He had been treated by many providers and who would prescribe medications to control his mood and behaviors without successful intervention. So under general anesthesia, he had an upper GI series, and this is the image that was obtained. This is an image showing the stomach and the duodenum, and as you can see, there's a corkscrew appearance in the duodenum. This is what's called a malrotation. This patient had a malrotation that was causing his symptoms, and when he had surgical repair of the malrotation, he stopped vomiting. He no longer had self-injurious behaviors. He no longer wore a helmet, and he was much calmer. But he continued to lack a language, but he was able to go to school and participate in activities. The second case is a 10-year-old boy who was referred for evaluation of repeatedly pressing on his abdomen. He frequently passed flatus, and his parents reported that his abdomen was often distended. He does not use the toilet to defecate and often will run around the house prior to passing a stool. This is a picture of his lying on a pillow, pushing on his abdomen. He often would jump on the bed and throw himself down on his stomach without any explanation, and these were not predictable events. When he had a KUB, you can see that there's a significant increase in the amount of stool throughout the colon, involving the cecum to the rectum. And when this was treated medically, he improved and his behavior stopped. So what are the medications that we use to treat constipation? These have been around for a long time, and most of the agents that are prescribed initially are agents that are osmotic agents that will help increase the fluid in the stool and hopefully increase the frequency of defecation. Lactulose has been used, but it can often cause increased gas. Magnesium hydroxide and magnesium citrate are more commonly used nowadays, but Miralax has been around for many decades and is often very effective. However, some information in the lay press has caused parents to be leery of using Miralax, although subsequent studies have shown that it is extremely safe. We try to avoid enemas in patients for many reasons, but if someone's impacted, that's an option. And then using lubricants like mineral oil, which are long time treatments, and the use of lubricants such as mineral oil, which have been around for many years, is often beneficial, especially for patients who have hard stools, who have difficulty in passing them. And then I often talk to patients and families about what I call a 3F diet: fiber, fruit, and fluid. The fiber is usually prescribed at a dose of fiber with your age plus 5. So if you're 5 years old, you would shoot to get. So if you were 5 years old, you would try to take in 10 grams of fiber. Fluid is water, and I'll have more to say about how much water one should take, but water is really one of the most important treatments for constipation. And then fruit, I tell parents that trying to give a pea fruit as a mnemonic to remember the fruits that are available, such as pears, plums, peaches, prunes, apples, which has 2 peas in it, are often beneficial in treating constipation, mainly because of the fiber content of the fruit. So recently there have been some new medications that have been available for individuals with constipation. These medications have been approved by the FDA for adults and are not approved for use in children. I've used them in a number of patients who've had refractory constipation, and many have responded. The first is lubiprostone, which is a locally acting chloride channel activator that enhances chloride-rich intestinal fluid secretion, but does not alter sodium or potassium in the serum. So this is an agent that increases fluid in the colon. Linaclotide is a 14 amino acid peptide that acts as a selective agonist, activating a guanylate cyclase receptor located in the luminal side of the intestinal epithelium in both the small bowel and the colon. This activation leads to increased cyclic guanosine monophosphate, anion secretion, fluid secretion, and intestinal transit. So that this is an agent that not only increases fluid in the stool from both the small bowel and the colon, but also increases intestinal motility. The third agent is prucalopride, which is a new chemical class that the derivative has a high affinity for the 5-HT4 receptors or serotonin receptors. The main target is the nerves of the gastrointestinal tract, resulting in acetylcholinesterase release and acceleration of propulsion in the colon. So here we have 3 agents that work by different mechanisms. Lubiprostone increases fluid secretion in the colon. Linaclotide increases fluid secretion and increases motility, and prucalopride is primarily a motility agent to increase contractions and propulsion in the colon. The other treatment that's very effective in patients with constipation is to use a squatty potty or some other means of elevating the feet so that the patient is in a squatting position. And this is often very beneficial because when you squat, you straighten out your sigmoid colon and make it easier for the stool to exit the rectum. Oftentimes, positioning is an issue, especially for children and adults who are on the autism spectrum, because they may not feel comfortable sitting on the toilet, and they may feel more comfortable passing a stool standing up. But this is a very difficult position in terms of trying to achieve complete elimination and evacuation of the colon. And finally, I want to emphasize the importance of water in colonic function. The colon's main job in life is to absorb water. And so if one is dehydrated or one doesn't have enough water, then the colonic motility slows down in an attempt to absorb more water. The stool becomes harder and the motility decreases. So often just providing increased water will make the stool softer and will also enhance motility. So the majority of school children in the United States do not drink enough water. And as you can see, the consequences of dehydration are not only constipation, but it also impairs cognitive function, ability to focus, ability to learn. It can impact on mood, and it can make individuals be more fatigued. So this is a dietary reference of water intake in children, and as you can see, for younger children, there's an intake of about 1 to 2 liters a day. An adult should strive for 3 liters, although we tell people that 2 liters a day of water is often sufficient. This is a list of goals for water intake that was put together by Kelly Barnhill. Taking 1 ounce of water per pound of body weight is a good way to remember the requirements for how much water a child needs to take. Replacing juice and soda with water is often beneficial, and flavoring water or using sparkling water is often a way to increase intake in children. And encouraging foods that are higher in water content is often beneficial, so like some fruits and vegetables, soups, or broth are often beneficial in increasing water intake in individuals. So this is a video of a young lady that was seen by one of my colleagues and friends, Dr. Tim Bowie, and this young lady's in class. She's working with her teacher, and as you can see, she suddenly loses focus on what she's doing. She drops her pencil. She's putting her head down, and her teacher takes away the pencil because she knows what's coming in terms of these behaviors, and you can see that she's having these sudden posturing and these movements. She has been seen by neurologists and thought to have a seizure disorder. She's been treated for seizure disorders, and these behaviors are spontaneous, unpredictable, and disrupt her activities in school. So she had an upper endoscopy that was done because people suspected that there might be a comorbid condition causing these behaviors, and sure enough, this is a picture of her distal esophagus, which shows ulceration and inflammation, and she had significant esophagitis, which, when treated, her behaviors resolved. This is another individual who has self-injurious behavior, biting her hands, hitting her head. And when she had an endoscopy, she also had severe esophagitis. And when the esophagus was treated with proton pump inhibitors, her her self-injurious behaviors resolved, and her the bruises that she'd had healed, and she was better able to participate in school. So this is the fourth case and the last case of this series of a 4-year-old boy who had nonverbal regressive autism, who presented because of diminished appetite, and also he was not taking in as much food. He had no self-injurious behaviors. His bowel movements were daily, and although they were occasionally loose, were not a problem. His weight was at the 70th percentile, and his height at the 42nd percentile, and he had a normal BMI at the 85th percentile. So he had an endoscopy to look to see why he was refusing to take food, and the biopsies were interpreted as being consistent with gastroesophageal reflux. And he was started on omeprazole, and his appetite improved, but his insurance company refused to cover the liquid preparation, and his family couldn't afford the cost, so they decreased the frequency of the medication. And when they did that, they noticed that when he missed a dose, he would awaken at night and have difficulty sleeping. Eventually, their supply of omeprazole ran out, and his food refusal and holding food in his mouth returned. So 14 months after this initial upper endoscopy that was consistent with reflux or with esophagitis, his food refusal had increased, his weight had decreased from the 70th to the 42nd percentile, and so a repeat endoscopy was performed. And these are the images from that repeat endoscopy that show some characteristic findings. First, you can see the linear furrowing, which is characteristic of a condition called eosinophilic esophagitis. And these linear furrowings were throughout the esophagus. And the biopsies that were taken were consistent with eosinophilic esophagitis. There were 22 eosinophils in the distal esophagus. Criteria varies among different individuals, but the criteria for EOE is thought to be more than 15 eosinophils per high power field. Some people use 20 as a number. He also had increased eosinophils in the mid-esophagus. And eosinophilic esophagitis is a condition that's treated largely by dietary measures, and at least initially. There are medications that one can take to decrease the inflammation if dietary management doesn't work. But he started on a gluten and a dairy-free diet, and within 3 days, he began to swallow food more and was trying new foods. And his parents, as well as his teachers at school and his ABA instructors, had noted a dramatic improvement in his ability to concentrate, as well as improvement in his mood. And this is another example of how pain or discomfort it can impact on mood and behavior, and then if one can figure out what the underlying trigger is for that comorbid condition, that children will do better in terms of their learning and their moods. So eosinophilic esophagitis is a condition that's associated with intolerance or to specific foods. In young children, regurgitation and food refusal and delayed growth are often the common manifestations. But in adolescents or in adults, dysphagia, food impaction, vomiting, and even chest pain are more common presentations. Eosinophilic esophagitis is diagnosed by endoscopy, where one sees an increase in the number of eosinophils in the esophagus. But there can also be surface aggregates of eosinophils which appear on endoscopy to be these white nodules, which I'll show you an example of in a minute, or you can have superficial layering of eosinophils along the esophageal surface. But the stomach and the duodenum are usually normal. Here's an example of an endoscopy in an individual with eosinophilic esophagitis. You'll note the white spots that are consistent with eosinophilic abscesses and the linear furrowing that's characteristic of eosinophilic esophagitis. These findings in endoscopy will resolve with effective treatment. I want to end this talk by discussing the relationship between the microbiome and behavior. This is a picture that was taken by a friend of mine, Dr. Cecil Fox. It's an image of the small intestine with this biofilm on the surface of epithelial cells, and within this biofilm you can see bacteria that are present. It's the relationship of this biofilm and the environment and the host immune system that impact on behavior in many children with autism. So this is an example of an individual with Parkinson's disease. Many patients with Parkinson's disease have a comorbidity that's associated with constipation, and alterations in the colonic microbiome have been described in individuals with Parkinson's disease. In one patient with Parkinson's disease, when the constipation was treated, the symptoms of Parkinson's significantly improved, suggesting that there is a relationship between either the discomfort from constipation and the symptoms of Parkinson's, or that altering the microbiome by increasing the frequency of bowel movements, some analogous to increasing the flow in a river, decreases the algae and the bacteria in the river. The microbiome being altered resulted in the individual having improved CNS function. There are other examples of how microbial communities in the intestine can affect behavior. And one of the more striking examples is Toxoplasma gondii, which lives in rodents in the desert. And when rodents are infected with Toxoplasma, they lose the ability to avoid areas where a natural predator, the bobcat, will reside. And so this loss of fear of the smell of the bobcat urine results in their being attacked by the bobcats, consumed, and then the bobcat will excrete the toxoplasma and reinfect other rodents. So this is an example in nature of how a bacteria can alter the behavior or the sense of smell of an animal and impact on its well-being. In humans, Toxoplasma infections have been associated with the propensity for high-risk activities and impulsivity. Other examples, such as brucellosis, have been associated with mania. Rabies has been associated with hydrophobia, and the most common in pediatrics is the association of streptococcal infections with pediatric autoimmune neuropsychiatric disorders. So, in children and individuals with autism, dysbiosis has been a common concern and one that has been studied by many investigators. And there seems to be a loss of diversity. There's an increase in certain bacteria. There's a decrease in other bacteria, both in the colon and in the small bowel. And the relevance of these alterations in the microbiome is not really clear. And more work is certainly needed to be done to understand the relationship between the microbiome in individuals with autism and the relationship between behaviors. In individuals with autism, Clostridia species are increased. There's an increase in Pseudorella species in both the ileum and the cecum. And in general, studies have shown that children with autism receive more oral antibiotics than children without autism, and this may also impact on the diversity and the stability of the microbiome in children with autism. So the points to remember in this talk are that behaviors are evidence for underlying comorbidities and should not be taken and treated as behaviors, but one should look for underlying causes that can be the triggers for these behaviors. So look for clues to identify the cause of discomfort or pain. It may be in the gastrointestinal tract, it could be an abscessed tooth, it could be some other cause of pain. And As we learn more about the role of the microbiome and its relationship to behavior, we hope to be able to develop effective therapeutic interventions. Thank you. So I want to thank my colleagues from whom I have learned a lot in terms of dealing with children with gastrointestinal issues. Tim Bowie, a colleague in Boston, Margaret Bauman, Raphael Kushak, who works in the lab with me and has done a lot of work on the microbiome, Kay Murray, one of the nurses who's worked with us, and especially the Autism Research Institute for their support of research and their quest to improve the lives of individuals with autism.
With your permission, I'd like to ask a few questions relating to your topic of gastrointestinal issues in individuals with autism. My first set of questions has to do with the fact that many persons with autism have limited or picky diets. When do you, as an expert in gastroenterology, become suspicious of the possibility of a micronutrient insufficiency, such as an insufficiency of a vitamin?
Well, I think any individual who has a diet that's restricted is at risk for developing micronutrient deficiencies or vitamin deficiencies. Patients who are on vegan diets or strict vegetarian diets may have decreased levels of vitamin B12. Folic acid can also be deficient in some patients. So one needs to always consider that, and especially in individuals on the autism spectrum who may limit their diets and their food choices to only a few foods, they may in fact be at risk for developing micronutrient deficiencies. So the only way to really, there are skin rashes or there are clinical features that one can see in specific deficiencies when they get to be severe, but usually one will detect them by measuring the levels in patients who have very restricted diets.
And in your clinical experience and based on the medical literature, are there particular vitamin insufficiencies that are more common in persons with limited diets who have autism or who are especially picky eaters?
I think that the micronutrient deficiencies that occur are based on the diet, so that if an individual is having a diet in which there's limited protein, so the micronutrients or the vitamin deficiencies that I traditionally check for are vitamin B12, folic acid, and vitamin D. Those are the ones that I usually check for in individuals who have restricted diets, and also in some individuals who may just have decreased caloric intake.
And along the same lines of questioning, Dr. Winter, what are the clues from an individual's clinical history or from the physical exam or from any laboratory testing that may have taken place prior to a clinical encounter with you that may sensitize you to thinking that an individual with autism might have a protein insufficiency in his or her diet, or a insufficiency of a fat such as an essential fatty acid in his or her diet?
Right. Well, in terms of protein, I think one needs to look at the diet, and we often have our dietitians and nutritionists assess the intake of an individual doing a 3-day diet history, so that we can actually determine how much protein, fat, and carbohydrate are being taken in by the individual. It's unusual to have malabsorption of a protein or fat in most individuals with autism, although we have seen patients who do have pancreatic insufficiency or have other underlying conditions that are associated with maldigestion or malabsorption. So one needs to keep that in mind especially in individuals who are underweight or have a low BMI or have fallen off the growth curve.
And Dr. Winter, how do you, as a specialist in gastroenterology and nutrition, think about and come to suspect the possibility of gluten intolerance in a child with autism who may have limited communicative capabilities?
Well, this is a challenging area because there's a lot of anecdotal evidence that gluten-free diets may be beneficial in some individuals who are on the autism spectrum. We did a study looking at a blinded study with patients, with children. We did a blinded study in children on the autism spectrum, and really couldn't see any significant benefit to restricting gluten from the diet. However, there are very credible examples of parents and families who have noted that when they restrict gluten from their diet, that their child's behaviors and activities are markedly improved. So I think one can't disconnect. I don't think one can discount this real-world experience in terms of understanding the role of gluten. Gluten is certainly known to be a pro-inflammatory food, and there are some patients that may benefit from gluten restriction. There's not really a good diagnostic test to identify patients who have gluten intolerance. If you have celiac disease, one can certainly make that diagnosis by doing an endoscopy or by doing a blood test called a tissue transglutaminase and an IgA level to determine whether or not the patient has celiac disease. But most individuals who restrict gluten from their diet do so based on a clinical observation that they see some improvement in their either their clinical well-being or in their emotional or physical or in their emotional or behavioral activities that they then feel that a gluten-free diet is beneficial. But there's no test that I know of that can predict which of those patients are going to respond to a gluten-free diet.
Thank you. Thank you. And Dr. Winter, there are some families who bring their children into clinical encounters who have placed their child on high doses of one or more vitamins. Are there possible toxicities from this, and when do you become concerned and counsel the parents about potential risks from this type of management?
Well, I think that certainly taking a history and seeing how the amount or the quantity of vitamins someone is taking is important. Toxicity is really clinical toxicity is really an extreme manifestation, and most of the time children will just have elevated levels, and we've seen children who come in with very high levels of vitamin D, for example, but they don't necessarily have any clinical manifestations of that. But we do counsel patients and families to avoid excessive use of especially fat-soluble vitamins, vitamins D, E, A, and K. And assessing levels is often a way to assist the family in understanding that they don't need to give these high levels of vitamins.
That's helpful. Thank you. Mm-hmm. And along that same line of questioning, Dr. Winter, some families supplement their child with prebiotics and or probiotics. In your expert opinion, when is such supplementation helpful, and when might it be concerning to you? When might it, for example, mask symptoms or cause other issues?
Well, prebiotics are essentially foods, so they're foods that bacteria like to eat, and those foods are often vegetables and grains and fiber, and so I think when we talk to families about prebiotics and probiotics, I think that taking a prebiotic is often beneficial in the sense that it will support the growth of beneficial bacteria. I don't like to use the word healthy bacteria because I'm not sure what that entirely means, but beneficial bacteria that are part of this ecosystem. We don't understand a lot about how the interactions work between different populations of bacteria in this ecosystem, so trying to fine-tune it with prebiotics and probiotics is really challenging. And I do get concerned that some families will spend a lot of their resources on purchasing probiotics that may in fact never get out of the stomach because the bacteria may be inactivated by gastric acid. So I think one needs to be careful about how one approaches this. There's some recent evidence that there are some bacteria that may be beneficial in patients who have constipation, and this is yet to be proven or documented well. But clearly, as we learn more about the microbiome, there may be bacteria that we can select to be beneficial. The best example of the prebiotic and probiotic relationship is in breastfed infants, because about 30% of the protein in breast milk is not digestible by the baby, and nature doesn't waste energy. So that if there's a protein in the breast milk, it's there for some reason. And it took us a while to figure this out, but now we know that this protein, which is not digestible by the baby, is digestible by bacteria, and by a specific bacteria. And this bacteria lines the surface of the intestine and protects the infant from getting an infection with invading bacteria. So this is an example of a prebiotic in breast milk that supports a microbiome that supports a bacteria in the infant that's beneficial. And I'm sure that there are other examples of this in nature. There are populations where individuals take in an excessive amount of fiber. They may take in 40 or 50 grams of fiber a day, and they have bacteria that digest those food substances. And it's hard to know because we don't really study those populations very well, but it seems that they have lower rates of many conditions, including autoimmune diseases. So clearly the role of prebiotics and probiotics is important, but from a clinical standpoint, I think it's hard to make specific recommendations that are evidence-based.
Thank you. And there's a subset of children, including children with autism, who repeatedly engage in eating non-nutritive materials, like either one type of material or many types of material, and therefore have pica. For you as an expert in gastroenterology and nutrition, what is your type of analysis in general in evaluating such children and caring for them?
Well, when I hear a story that a child is chewing on things and is eating non-nutritive substances, one certainly thinks about iron deficiency and nutrient deficiency is a cause of that. But as a gastroenterologist, the first thing that comes to my mind is this child chewing on substances or non-nutritive foods in an attempt to increase their saliva? Why would a child want to increase their saliva? Well, if they're having gastroesophageal reflux, saliva is a great buffering agent for acid. So this is the way for the child. By increasing the saliva, they're essentially neutralizing the acid, this reflux, back into their esophagus, and that's then making them feel better. So that reinforces that behavior. So that's one of the first things that I think of when I hear a story of children chewing on their clothing or chewing on non-nutritive substances, that this is a manifestation, or this is one of these clues that we look at to say, well, is this child having gastroesophageal reflux, and do I need to do additional investigation to identify that?
I see. Thank you. And when you see in your clinic a child with autism who has frequent spitting up or recurrent vomiting, what are the clues from that individual's clinical history, his or her physical exam, and any prior laboratory testing that will push you into thinking about the possibility that that person's recurrent vomiting may be due to some type of inborn error of metabolism?
Strange you should ask that question. So I think that trying to distinguish, certainly when a child has recurrent vomiting, there's a long differential diagnosis. And it includes anatomic abnormalities such as an antral web or a malrotation. It includes some gastroesophageal reflux, where the sphincter or the barrier between the stomach and the esophagus is somewhat incompetent, and so a child will have regurgitation. And it also includes metabolic abnormalities. And interesting, one of them, in my experience, one of the common causes of reflux is constipation. When a child is constipated or not emptying their colon completely, and their colon is distended, the gastric emptying is decreased. And so when the gastric emptying is decreased, you have an increased risk of having reflux. So oftentimes when you see a child who's having regurgitation or vomiting, one should always think about whether or not there's an increased stool burden contributing to that. Because oftentimes when you decrease the stool burden and you increase the motility in the colon, the stomach will empty better and the symptoms of reflux will get better. So in answering your question, because I want to get back to the metabolic thing, because I know that that's what you'd be interested in. What are the conditions that we know of that contribute to colonic motility issues? Well, one of the most common ones, and it's not that common, but one of the ones that we always think about are mitochondrial defects, because mitochondrial defects can present, and often do present, with constipation. So there are patients who have individual, who have isolated colonic dysfunction and mitochondrial disease, but oftentimes mitochondrial dysfunction is a more systemic or a more global condition. So if I have a child who's got constipation but also has hypotonia or other neurologic seizures, then I think about a more global issue such as a mitochondrial defect.
And in your talk, Dr. Winter, you presented some really interesting ideas and information about the role of the microbiome. Are there situations now in clinical medicine where primary care physicians or where specialists such as yourself in gastroenterology order specific testing to evaluate one's microbiome?
So there are not really clinical tests that allow you to assess the microbiome. I mean, you can look at the microbiome with very sensitive tests, but how to interpret them is really challenging. So we don't really use it on a clinical basis. We do on a research basis, trying to understand the relationship between the microbiome and certain behaviors or activities. And in other conditions, such as inflammatory bowel disease, we are trying to look to see if there's a relationship between the microbiome and certain responses to medications. But in autism, we don't really have that knowledge yet to be able to apply it clinically.
Thank you so much for a wonderful talk and for helping us to understand these important issues.
My pleasure. Thank you.